and jump in here before I hand it over to Mike and Todd. Just wanted to welcome everyone to Fitch and Associates Pinnacle webinar series. Today's presentation is Meaningful Improvement Using Data, sponsored by First Watch. And before we get started, I just have a few announcements and reminders. First, Pinnacle 2023 is just a short couple months away. This year's will be held July 24th through the 28th in San Antonio, Texas at the beautiful JW Marriott Hill Country Resort. Be sure to take advantage of the early bird pricing now through June 1st. You can learn more and register at pinnacle-ems.com. And I want to thank each of our webinar sponsors. We are grateful to First Watch, a Pinnacle strategic partner, as well as today's presenter. Thank you also to our learning partner, Ninth Brain, and our premier media partner, EMS One, who provides support in bringing you these sessions. And moving on to our presentation, as a reminder, please feel free to use any of the buttons at the bottom of your screen. There is that chat, which you all have found, and a raise hand button. And there's also a Q&A button if you want to put some specific questions in there. We'll also use the chat feature to put any, to share any links. And if you want to join in the conversation, you can raise your hand and we can unmute you. As a default, everyone is in listen only mode, but we can do that if you want to join in, just let us know. With that said, I am pleased to welcome Mike Tagman and Todd Stout from First Watch, and I'm gonna just pass it along to them to get started.
Thank you so much, Amy. We really appreciate
it.
So I'll just do a quick introduction and then get out of the way, because whenever I talk with Mike, that's who everybody's there to hear and listen to anyway. So we'll get there. We're very excited to have everybody here and see Mike's calendar and know what he's working on. It's great. We also see your slide presenter mode right now, Mike.
Do you? You want me to switch to the other ones?
Unless you want us to know what's coming, which is for me much more exciting than just seeing what you want me to see.
All right. How's that? Is that better?
It's better. It's better. So thank you all. We're super happy to sponsor this webinar. I always have known Mike for over probably 40 years, and I learn stuff every time he talks. And which is why I see so many friends already on here that I know a lot of this. For those of you who don't know First Watch, we really connect to data like phone, ProQA, CAD, electronic patient care record, or RMS data, and do a lot of work with it. Really, we use technology and what Mike's going to be talking about, the science of quality improvement and meaningful improvement, to make things better for our customers, folks like you, and the people that you serve. So we're super happy to be here. I will put a little plug in for Pinnacle. Pinnacle is just a wonderful leadership conference. If you haven't been, I strongly recommend that you try to make the time and go. If you do go to Pinnacle, please come see us. We'll not only be in the booth, but we'll have a suite again this year. It'll be our first one since COVID. And we're sure excited to see everybody. We'll have the suite really every night that we're there. And it's a great time to sit and just talk and brainstorm and give Mike crap. So I'll turn it over to Mike.
And what Todd means by suite is free drinks and free snacks and that kind of stuff throughout the whole show. It's pretty fun. So thank you, Todd. Thank you, Amy, and the whole Fitch team for partnering with us and allowing us to put this on. And from the attendee list, as I mentioned before, all of you got on. There are several of you on this list that could do this presentation. And since we've got people at kind of varying levels of skills, I want to start by just kind of grounding us and what we mean when we talk about improvement. We're going to do a deep dive into some of this stuff, and I've got the chat up. So if you've got questions or anything in the chat, you can just pop them in there, or the rest of the team will watch for hand raising, and you can unmute and interrupt or whatever any point in time. We'll take care of that. Those of us that have had the opportunity to visit lots of EMS systems, and I see like Shannon Marshall's in the group here, who's visited lots of places. Everybody has got something that they call quality. It's quality assurance, quality improvement, total quality management, their quality function, whatever it happens to be. And when you ask them that question, so that, that's great. What are you doing? And they'll say, we do 100% chart review, or we do peer review, which is always cute, but doesn't necessarily produce anything meaningful. I ask the question. So that's great. What have you improved? Which kind of brings them up short most of the time. And if they answer anything, they tend to point to some kind of a documentation process. And most of what they're describing is a function in the organization that is kind of like seeing a patrol car in the rearview mirror. You kind of, function as like the internal affairs division of the EMS system or organization you're working with, and got systems to find the bad apples in the process, and then do some kind of a performance improvement plan that is designed to make that bad apple a better apple. And that's the quality framework that most of our industry, unfortunately, is still steeped in, and is certainly the one that I started off with and grew up with. But they're really systems for taking whatever money you've set aside for quality and putting them in the shredder. They don't produce anything of good results. So when I think about a quality management system, I think of three big buckets, and actually Mick Gunderson, I saw, is on here. He and I have been teaching this stuff almost as long as Todd and I have known each other in one way or another. And the fundamentals are, you need some vital signs that you're monitoring to let you know how your system's doing. How's your system performing? You need to have an actual framework for making meaningful improvement. And you also need that little bucket for those sentinel events, the complaints, investigations, et cetera. We're going to focus today on using data to kind of monitor and improve. And just I'm going to do this next part quickly, but just to ground people, most of you have probably been exposed to the model for improvement. This was developed by the Associates in Performance Improvement, based in Austin, Texas, and they were part of Dr. Deming's road team for years. And the framework is a simple construct that has got a lot of depth and power to it. It starts off with 3 questions and then moves into a strategy for testing change ideas. So the aim is, how much improvement are you going for, and by when are you going to try to improve it? So it's like, what is it you're actually trying to accomplish? And to give you an example, I was working in Ventura County, working for AMR at that point in time, and met some folks at a political fundraiser who ran 2 local hospice organizations, and they stopped me and said, why do you guys always transport our hospice patients to the hospital when they don't really want to be transported? And I said, well, if 911 gets called, that's kind of what we do. We tend to be a transport entity. Talk to me about it. And they explained to me the problems with that. And so we put together a performance improvement project focused on improving the care of hospice patients who had 911 activated on their behalf. So I don't know how many of you have had experience with hospice in your personal life, but both of my folks were on it. This is my dad shortly after he got put on hospice, reading to my son. And when you sign up for hospice, they come to your house and they tell you about what the benefit covers, and they give you this little comfort care kit, which has got liquid morphine and atropine and Zofran and those kinds of things that you keep in the refrigerator so that you can do the medication management yourself. And the first thing they tell you is, look, if anything changes with the patient, don't call 911. Call this 7-digit number and talk to our hospice nurse so that we can get things taken care of. You do not want to activate 911. The 911 system really doesn't know how to handle hospice. So we put together a project, and our aim was to keep hospice patients who had 911 activated on their behalf within the hospice system, and keep them from being transported to the hospital and manage them at home. So the next question in the model for improvement is, how will we know that change is an improvement? And this really talks about our measures. And when we're talking about improvement, we generally talk about 3 different kinds of measures. The outcome measures, the results you're trying to achieve. Process measures are those things that if you do them well will result in the outcome. So, for example, in cardiac arrest resuscitation, the time to first compression is a process measure that helps produce the outcome of being resuscitated neurologically intact from your cardiac arrest. And we know that if you don't get a compression in a reasonable amount of time, your likelihood of being able to be resuscitated is much, much lower. And then the third type of measure is a balancing measure. And those are the things that can go sideways potentially if your project does certain things, can send things off in the wrong direction. So for this hospice project, our outcome measure was the percentage of 911 calls for hospice patients that result in a transport. And our goal was to reduce the number of those patients that were transported. The process measure, in this case, our main change idea was to train our paramedic supervisors in the same curricula that a new hospice nurse would be trained in if she or he were joining a hospice organization, and have them respond along with our paramedic ambulance crew and fire first response partners to any 911 call that had hospice associated with it. So at the beginning, there were a number of our first response fire agencies that didn't want anything to do with this process, so they wouldn't activate our community paramedic hospice trained person on the calls. So increasing this was a process measure that helped produce our outcome. And then in our current reimbursement scheme, where you get paid for transporting patients to the hospital, and we were a fee for service based funded ambulance service. If you don't transport, you don't get paid. So the balancing measure was the amount of revenue lost from transports. So that's a way to think about defining measures around improvement. And then the next part of this model for improvement is what changes can we make that will result in improvement. This is your theory about how things should be. These are your ideas about if we do this, it'll help produce this result. And everybody's got a theory. Would you just, for the fun of it, type into chat whether you think the one on the left side of your screen or on the right side of your screen is the correct way to put toilet paper on a roll. I want to see the theories in this group. So Mick says left. Kyle says left. Look at all these left people. Left, 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 left. Look at this. Left, 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 right. Oh, Brad says right, because that way the cats won't undo it. All right, this is good. Everybody, I'm glad. Thank you for that. Twink Dalton's in the room. That's exciting. Sorry about that. I got distracted for a second. Interesting. The original patent for the toilet paper roll does in fact show it on the left. But those of us that have toddlers or cats tend to prefer it on the right so it doesn't get dumped all over the place. And one of the things about improvement science is when you've got theories, you're actually supposed to test them. So EMS has this habit historically. We're getting better, but historically we come up with these theories and we implement them without necessarily testing them adequately. So I know many of you in here are old enough to remember when you immobilized the spine of everybody who didn't just have chest pain, right? Or some of you remember this particular device. It was like, it was, great. It was based on a theory, from the G suits, from fighter pilots, and, we'd keep the blood and the heart and the brain and save lives. And it turned out we actually harmed more people than we helped with this device, even though you produced dramatic results from it. So once you've got your theories, then you put those into the bottom part of this model for improvement, the plan, do, study, act cycle, where you're doing tests of change. And you do this by making small, fast tests of change. The idea is to make them as small and fast as you possibly can. So as part of your plan for a test, you predict what you think is going to happen, and then you go ahead and do it and try and gather some data and whatever you're measuring and whatever other learnings you might have. And then in the study phase, you compare the results of your test with your prediction. And then based on that, you decide in the act phase, are we going to adopt this, adapt this, or abandon it? So, one of our first, this was more of a knowledge gathering PDSA cycle, was to just go out and ride with the hospice nurse while she visits patients and see what there is to be seen and see what there is to learn. So the prediction is that we could learn how to better understand hospice and keep patients in hospice by looking at things through the eyes of a hospice nurse lens. So I did a ride along, went and saw 9 different hospice patients, gotten involved in a huge family conflict in the process, learned a whole lot. And then I was able to compare the study perspective of, we learned a whole lot more than I anticipated learning. And we decided to adopt this as a practice. So all of our paramedics went and did ride-alongs with the hospice nurses, and we had them participate in the weekly summit that the hospice physician would do with all of their hospice team as they reviewed all of the patients they had on hospice. We learned a ton about how to take care of patients better. And then as you do these practice cycles of change, you work to build a degree of belief based on actual evidence, meaningful change and improvement in your organization before you get up to doing implementation. So you start with the smallest test you can, do follow-up tests, then do some wide-scale tests before you go to implementation. Historically, EMS has gone from interesting idea to full-scale implementation. That's how we got mask suits required on every ambulance in America early on, and those kinds of things. And then from the data perspective, what you're looking to do, and we're going to spend time teaching you about how to think through control charts. But in this one here, we started off with our baseline. 80% of 911 related hospice patients got a ride to the hospital. And then after we went live with our community paramedic program, we were able to drop that transport rate down to just around 34%. And then we worked at that level for a few years, which was a dramatic improvement from the hospice team's perspective, until all the rest of the first responders and everybody in our system was really attuned to the practice. And we made it so that everybody in the system could take care of these, not just our community paramedics, and have dropped the transport rate down to 17%. So when you're looking for making meaningful improvement, this is the kind of thing that you're going to want to see on your charts. And then the last part of this model is, once you have learned something and made significant improvements, you should contribute to the literature and the data in the world, and spread it by sharing posters at conferences. The National Association of EMS Physicians now accepts improvement science posters at their conference. There are a number of other conferences that do. The Institute for Healthcare Improvement has a massive poster session at their annual conference, which you can submit to, and it's a really fun one to attend. You can also do a peer review publication of improvement science projects. The Pre-Hospital and Disaster Medicine, the NMSP journal, as of a year and a half ago, now accepts those as well. And I was gonna shout it out to Mick, but Mick just posted it in the chat as well, that the International Journal of Paramedicine also accepts QI project papers. And Mick, I would invite you, if you're up for it, to go ahead and add a link to the chat to your journal, so that folks can see it. It is a pretty massive undertaking and a lot of good information there. So when we talk about improvement science, we're frequently referring to Dr. Edward Deming. He is. There are a number of other people that contributed, but he's been the main influencer that we focus on, and he's a pretty quotable guy. One of the things he frequently says: "In God we trust. All others must bring data." So the way we're going to be talking about data here, it works for monitoring your performance overall, your outcomes process, and balancing. And Todd thinks it's you may need to replant your link there, Mick. I think you can put an actual link in there, just so that folks can click on it and find it. So, oh, there you go. Alex put it in for you. There you go. So when it comes to improvement science from the Deming perspective, he really talks about 4 lenses of improvement science. There's understanding the systems view, the psychology, the building knowledge, which is really the PDSA cycle, and then understanding variation. So we're going to focus the rest of our time on really the data part, which is understanding variation. And remember, as we talk about measurement, there's an old Palestinian proverb that I love that says, just measuring things doesn't necessarily change it. Okay. So this next is a trivia question. Who knows who this is a picture of? You can type that in your chat, and see who knows who this is. We'll see who the first one is to get it typed in. Florence Nightingale, Beth Adams. Thank you for being here. Well done. Look at all that. Lincoln's wife, Daryl. Come on, really? This is Florence Nightingale, and Florence Nightingale is really known as one of the founders of the practice of nursing. But what I really admire Florence Nightingale for is she was really one of the first data-driven improvement scientists in healthcare. So she was working with the British government and the British troops in the mid 1800s in a war in Crimea. And she used this particular chart as a way to convince the British government to make some changes and make some improvements. So the way this chart works here is this is by month. So this is April 1854, May, June, July, and it just kind of stars out around that. And what the little red slice in the middle is, these are soldiers that died from their wounds. They were shot by a cannon or shot by a rifle or stabbed with a bayonet. They actually died from their wounds. This next little brown level out here, these are people who died from falling off a cliff or having a wagon drive over them or something like that. And this big gray outer circle are folks who died as a result of poor sanitation. They didn't have good waste disposal systems in the camps where the soldiers were. The food was not prepared in a hygienic fashion. Wounds were not managed effectively. So she basically took this exact chart to British Parliament and said, hey, we are killing our soldiers because we haven't provided them with adequate, living circumstances. And the enemy's not killing them, we're killing them. So she got Parliament to cough up a few million pounds worth of resources to dramatically improve the sanitation conditions. And you can see here, this goes from March 1855 to April 1855, and you can see the dramatic decrease in the gray chart here. And this shows measurable, meaningful, life-saving improvement using improvement science and data methodologies. One of the first ones that we know of anywhere. So as we get closer to modern times, this is the Hawthorne plant in Cerrito, Illinois, Western Electric plant, and they manufactured telephones here, and they were having problems with quality of the telephones they were manufacturing. And they had problems with uniformity, and many of the phones didn't work coming off the assembly line, and the person who was running it was in a panic. Oh my God, what do I do? He basically reached out to inside Western Electric. They had this think tank of people who could solve challenging problems, and that was Bell Laboratories at Western Electric. And within Bell Laboratories, there was a statistician, Walter Schuhart, who was kind of given the assignment of how do we sort this out? How do we deal with quality around this? And he invented some approaches to statistics that helped you understand variation. And he talked about it as the common variation within data, and he called it assignable. We tend to call it special cause variation in data now. And you've all been in meetings where somebody will throw out a table full of numbers like this, and somebody in the room will start circling the numbers, and and usually it's somebody of a higher rank in the organization, and they're going to look at people who are not of higher rank in the organization, and they're going to ask them a challenging question. Why is this whatever it is? And they're all various versions of this next slide. And this next slide, if you don't remember anything else from this entire presentation, this next slide is the most important piece of information you'll get. A whole bunch of my friends who've heard this before know exactly what's coming. But if you're not going to take a note on anything else, take a note on this one. And that is, given two different numbers, one will be larger. And if I could see your faces on the Zoom, I would likely see some of you roll your eyes. A couple of you would probably flip me off. And it's like, that's ridiculous. I mean, of course, if one number is bigger than another, but the level of newspaper headlines, research study headlines, publication headlines, actions that have been taken, conclusions that have been drawn based on this fact in an erroneous fashion is pretty much overwhelming. And all you have to do is, go to the CNN website and look at the stock market, and you'll see the stock market pages, the stock market now, and it'll give you in green colors and red colors, the changes to tell you that one number is bigger than another number, and they'll tell you the world market, and they'll color code the world market for you, basically telling you one number is bigger than another number. All these really elaborate ways to do that. And sometimes you'll get three numbers, and people will say, wow, we've got an upward trend, or they'll say, oh, this is a downturn, or this is a rebound. This is a rebound. This is a setback, and this is a turnaround, and this is a downward trend, and it's all 100% BS. It's just not meaningful at all, and the way, and the reality is, Todd Stout, his internet is crapping out. He'll start and rejoin. We'll see you in a minute, Todd. We use data for everything every day, even if we don't think about it, and we draw conclusions based on it that sometimes don't necessarily make sense. There's a probability of not hitting the jackpot is crazy, but there is like that one chance. So people still buy tickets, which if you understood the science probably wouldn't. Occasionally you'll see graphs like this. Our friend Brad Kramer here, this is from Santa Cruz, and this shows this correlation between shark attacks and ice cream sales. So the conclusion that people might draw from this is that if we quit selling ice cream, we would decrease shark attacks. That would be the strategy to be able to prevent shark attacks. And these kind of correlations do not equal causation. They just happen to be interesting together. You can find all different kinds of things on the internet. So this is the correlation of per capita cheese consumption and the number of people who die by being entangled in their bed sheets. Or this one here is the Justin Bieber effect. So the serum cholesterol level for men and women. Men is in the blue dots, purple is the female. And when Justin Bieber was born, the serum cholesterol level went down in this country. And then Facebook was invented, and Facebook killed the Justin Bieber health improving effect of decreasing serum cholesterol, which is, of course, crazy, but people will publish these charts and make conclusions around it. People will use it for advertising. Alex says, what if we get sharks to eat ice cream? I love that. So this was an advertisement that Chevrolet put out. And basically what the ad was is that, of trucks that have been on the road for 10 years or more, Chevy trucks have the highest rate of still being on the road 10 years or more. And it looks pretty dramatic here. But if you look at the y-axis on this particular chart and realize it's a 95 to 100% y-axis and you correct it, this is what that chart looks like. And it's not nearly as dramatic a difference. And newspapers do this all the time, and EMS people do it in reports to their board, things like this. There's been a massive increase in house prices this year. Again, you look at the y-axis. If you correct the y-axis, it's like, yeah, there may have been an increase, but it's really one number bigger than another. And of all of the fancy ways you can display data using Tableau or Power BI or any one of a gazillion different systems out there. People love their pie charts for some reason. This is a couple of years ago, the popularity of Halloween costumes. I think this year my son was a pirate here. And pie charts are notoriously difficult to extract meaningful information from. Stephanie never lets me down when I show this slide because she loves pie. And the two leading data display scientists in America, one of which is Edgar Tuffy, says the only thing worse than a pie chart is several of them. And this is Stephanie's chart right here. Maybe this is a sweet potato pie, Kenneth. But this is the only pie chart that we actually allow here. And people do strange things with bar charts sometimes. So here's a bar chart that you might see in any one of a dozen, research studies or articles or publications. But the data from this could look like this in a performance over time chart, where it looks like the data was going down and the change didn't necessarily have a lot to do with it. Here, this is the change was continuing to head down and didn't have much to do with it. Here, and these are all from the same two bar charts, looks like the change was going down and then it took off back up. So when you do these two bars, one number bigger than another, it is the equivalent of taking a snapshot on your phone, whereas using data over time is really like grabbing a video in a movie from your phone. It'll give you a lot more information. So one last example here, and this comes from our hospital partners. And hospitals love these true north boards. And my grad students, almost all of them, work at institutions that have true north boards, and they look at patient safety events and people getting the eligible care and their urinary tract infections and central line infections, and they color code them. And if something is color coded red, that means somebody's going to get a talking to and said, you need to improve this. If it's color coded green, somebody's throwing somebody a pizza party. And when you look at the data in a control chart behind these, you'll realize that in this particular case, this is safety events per 10,000 adjusted patient days. They've got a goal line in here, and their goal line is here in the middle. And these two dots were above the goal line, and they got colored red. And this dot was below the green line, or the blue line, and it got colored green. And from a statistical perspective, we're going to show you how to do this in just a second. There is statistically no difference between these two dots and this dot, but we color them in a way that gives the illusion that there's a difference. Here's another example from that same True North board. This is on the percentage of eligible patients receiving perfect care, which is the bundle of care that's defined for those. And you can see that this hospital system has gone from about 46% of their patients getting perfect care to 74%, and now they are up around the 90% level. So they have made dramatic improvements, but their organization has got a 96% goal line that they've never hit, so they've never gotten a little green dot. So this is a system that the leadership team is probably bashing them constantly because they're constantly getting red colors and not seeing the incredible dramatic performance improvement that they've done that is hidden in the one number bigger than another number chart. Okay. So one more Deming quote here. Without data, you're just another person with an opinion. So when it comes to building these performance over time charts, and these charts really allow you to predict what's likely to happen in the future from a process. And we have an X and Y axis. The X axis is your naturally occurring time order, whether it's by day or by week or by month or whatever your rational subgrouping is. The Y axis is whatever it is you're measuring. And one of the things we always say to folks whenever they're starting an improvement project is let's start by just plotting the dots. Let's just start by plotting the dots. And so what this chart measures is this is by day. This is when I lived in Pinellas County, Florida, and worked there. I had a house in Clearwater, and our office was in Largo, Florida. Some of you, I think Mick has actually been to both that house and that office, along with a couple of others. But this is the number of minutes that it took me by day to get from my house to the office. And these are, you just start by just plotting the dots, just by understanding what your process produces. And you don't want to do the, ask questions about these dots of, Mike, yesterday it took you 40 minutes to get into the office. Today it took you 29 minutes. What happened? Because anytime somebody who's above you in the organization asks you a question like that about one number being bigger than another, you are compelled to come up with an answer that is logical, rational, compelling, and 100% fabricated BS. I would say I caught all the lights green, or I didn't stop for coffee, or whatever the story happens to be. But the reality is, these dots here are all what are referred to as common cause or random variation. The other phrases that you will hear used to describe a process that produces results like this is a stable process or a process that's in control, in statistical control. It doesn't mean it's good or bad. It just means it's in control. So one morning, as I was riding my little Harley 1200 custom Sportster to the office, I came up on an intersection. And the question you get to ask of this kind of variation is this performance good enough? But I came up upon this intersection. I was driving this direction, and I stopped at the red light. I was the first in the line of cars at the red light, and a little Toyota pickup truck blew the red light coming the other direction and was double broadsided in the driver's door and passenger's door. So I, turned off my motorcycle, put my kickstand down, and went over to play paramedic. A bunch of other people were on their cell phones, so I knew 911 was being called. And I got to the pickup truck, was able to reach in through the smashed passenger window and see that the patient was unconscious, had snoring respirations. I could feel a little subcutaneous emphysema on the left side of his chest. So he had a pneumothorax. I reached down and felt an unstable pelvis, and his left patella was touching his left symphysis pubis with an angulated femur fracture. So he was a major trauma case. Also, he was wearing an EMT uniform. He was an EMT that worked for our system, had worked a night shift and hadn't gotten adequate rest the day before, and fell asleep and blew the red light and got double broadsided here. It was early morning traffic with a big traffic jam. And those of you who've spent time in Pinellas County, you know that it is some of the highest concentration of elderly folks in America. Actually, Clearwater historically holds the record for the highest percentage of citizens over age 100, and they all still drive. So rush hour traffic is really a traffic jam. So we activated Bayflight helicopter and got him extricated, loaded him in the helicopter, paralyzed him and tubed him, vented his chest. And I flew off, jumped in with the helicopter crew to fly with him to the hospital, and we got him sent off to the operating room to have his femur and his pelvis externally fixated, and he got his chest tube and all that kind of stuff. And a buddy of mine from the sheriff's office was there and said, offered me a ride back to my motorcycle. So on this day, how long it took me to get to work was a little over 2 hours and 10 minutes. So that little dot up there is what's referred to as special cause or non-random variation. It happens outside of the normal process. Some people, when you see this on a control chart, will call this an unstable process or a process that is not in statistical control, out of control. And the question you get to ask of this is, what happened here? What is it that happened here? So there are a batch of statistical rules, and I'm going to run through them fairly quickly here for both run charts and then for control charts that help you distinguish common cause or random variation from special cause, non-random variation. You don't need to memorize all these. If you want the slide deck afterwards, send me an email. I will happily email you the slide deck. You can Google these rules. They're easily available. So you don't need to memorize them. But you know, one of the things I found is after you've worked with them for a while, the main ones really stick in your head. So for a run chart perspective, and we use run charts once we've got 12 or more data points, but we don't quite have 20 yet. So between 12 and 20 data points, we plot the dots, and then we do a calculation, and we'll plot the median line on these charts. And Excel can do this for you. There's a number of programs that'll help you do that. It's pretty easy to do by hand also. But if you get a batch of 6 or more data points above the median or below the median, that is a special cause rule that says you can ask the question, what happened here in a chart like this? A trend in a run chart, and you'll see this is different than a run chart and a control chart, but a run chart, if you get 5 or more continuously ascending data points or 5 or more continuously descending data points, that's a trend. And a lot of people will ask, well, what if you get 2 points in a row that are exactly the same? So if you get 2 points in a row that are exactly the same, that doesn't add to or take away from the count. So on this first one, you get 1, 2, 3. You count that one as 4, 5, 6, 7. So you've got 7 continuously ascending points here. So this is a statistical trend here. And then this next one is one that you can probably catch with your eye. Too few or too many runs. And what a run is a gathering of points above or below the center line, the median. So here is 1 run, and here is 2 runs. And if you're wondering, you know, how do you calculate how many is too many or too few? There's a little chart they provide, which will tell you if you've got 10 data points, you should have between 3 and 8 of these runs. So in this particular chart, you've got 10 data points and you've only got 2 runs. So in this case, it is it's too few runs to make that up based on this chart. If you've got 25, you should have between 9 and 17 runs in order for this to be considered special cause or common cause variation if it's between these two, special cause if it's below or above. And then if you get a astronomical data point that's just way above or way below, that is another clue for special cause variation or non-random rules for run charts. So there's basically 4 of those rules. And let's just do a quick test. You can type your answers in the chat here. So what do you see here? Is this common cause or special cause variation? And too few runs. Brad says too few runs. So if this is a run, and we're not sure if this one's above or below the center line here, but if let's say it's below, then there'd be too few runs. There's no trends, and there's no, but there is potentially a run 1, 2, 3, 4, 5. If it's exactly on the center line, it doesn't add to or take away. So this isn't quite a positive clumping yet. If you get 1 more data point above, it would be, but you've got too few runs here. Good. Special cause deviation. And the question you get to ask of special cause deviation is what happened here. So let's take a look at this one. What do you notice on this one? You can type in the chat. What do you see here? This is people who've got their chat open and aren't playing Pac-Man on the side while we're doing this. This is good. All right, so you've got 1, 2, 3, 4, 5, 6. So you've got a trend upward trend. Well done, Daryl, Brad, good job. And that's the key on this one. Okay, time to celebrate with the team. There you go. What do you see here? This one's pretty obvious, an astronomical point. And this case, you can probably guess if you look at the table here. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 data points. So with 14 data points, we would expect between 4 and 11 runs here. In this case, we actually have 13 runs. So Kenneth says it's time to shock. Exactly. This is something you might want to consider defibrillating. So yeah, who's working? Twink, exactly. Those are the questions that you come up with. So those are the rules for detecting non-random variation in a run chart. In a control chart, we've got the similar kinds of things to a run chart. We plot the data in its naturally occurring time order. We have a center line, but in this case, the center line is the mathematical average of the data, not the median. Okay. And then we use a little bit of statistical calculation for calculating 3 sigma above the center line and 3 sigma below to create an upper control limit and a lower control limit. And if you're interested in the math on that, happy to send you the math. It will drive most of you crazy, so I'm not going to go over it here. But if you get a data point above the upper control limit or below the lower control limit, that's a sign of special cause variation. When it comes to runs, in this case, when remember in a run chart, you had 6 or more data points clumped below or clumped above the center line. In a control chart, you need 8 or more consecutive points above or below the center line. So here you've got 8 data points below the center line. Here you've got 9 points above. And when you're doing performance improvement, this is really what you're hoping to create. So if up is good, you would like to create data where your performance shifts up, and that's one of the ways you're able to say that you've actually made meaningful improvement. On a run chart, it was 5 continuously ascending or descending points. On a control chart, it is 6 continuously ascending or descending data points. Okay, and so if you understand the point above or below the upper and lower control limit, understand the run of 8 or more consecutive points above or below the center line and the trend here, you will catch most of what you need to know. Brooke said, can we make up a rule that up is always good? That is a NEMSQA comment. I haven't seen Michael Redliner in here, but that would be his approach. I appreciate that. And I know you're on the board there, Brooke. Thank you for contributing. I'm gonna share with you these next 2 special cause rules. They are subtler and ones that many people don't find as practical, but I want to share them with you just for my data geeks so they're complete. So if you get 2 out of 3 consecutive points in the outer 1/3 near the outer upper or lower control limit. So a lot of software programs will put the third lines in here so that it's easier to do this. But in this case, you've got 1 and 2 of these 3 data points that are in the outer third here. Down here, you've got another version of it. You've got 2 out of either of these 3 that are in the outer third. That's another sign of special cause variation. And then here, if you've got 15 consecutive points hugging the center line, close to the center line, the inner 1/3, if you've got 15 consecutive in the center line, that doesn't happen randomly. That happens by special cause. And Mick called that zone A and zone C. Thank you for that. It's another way to look at this. Well done. So when it comes to looking at your own data for both monitoring and performance improvement, one of the questions that I always ask when you spot special cause variation, is this special cause variation that you intended to create? Was it by design, or was it by accident? And if it's by accident, something changed in the system that you didn't intend to cause, that's think of that a little differently, and then as opposed to something that you purposely intended to change. So if you're looking at your customer satisfaction scores and you want your customer satisfaction scores to go up, and you have done a lot of work with your crews on customer service training and all that kind of stuff, then seeing this as be something that you intentionally caused, that's exactly what you hope for in performance improvement, similar to what we already looked at on the hospice control chart. And so one of the things that sometimes people, when they're new to this, they get a little bit confused about. They'll say, is common cause variation good and special cause variation bad, or is it the other way around, that special cause variation is good and common cause variation is bad? And neither of those things are true. It is just, all special cause variation means is that something outside of the base process has happened. A different process produced the results that you're seeing. And if it was intentional and it is going in the right direction, then you could say that is good. But you don't know without the context. You can't tell just by looking at a chart. I'm gonna give you one other way to think about this data, and this is a little bit different than performance over time, but it'll give you a good look into your system. So this is an EMS system somewhere in America that shall stay unnamed. It's a busy system. And what this is one data point for the name of each paramedic in the system. And these are medics who have all taken care of more than 200 acute coronary syndrome patients in the last 2 years. So this is a busy system. And these folks take care of a lot of patients with chest pain in their system. And so this shows, you've got your bundle of care. So you're supposed to, get a 12 lead within 5 minutes of patient contact, give aspirin unless they're allergic to it or are already taking their aspirin, give a nitro if their blood pressure systolic is over 100 and they're not on erectile dysfunction medications, whatever the bundle of care looks like for them. And so what this chart shows is that you have got one medic who 80% of the time has cared for patients the way your system says is good quality care. And you've got two medics here who've never, out of 200 cases, ever taking care of patients in a way that your system has said is good quality care. This shows that your system overall, about just under 30% of patients get the care that they intend to get. So these are another way to use this type of chart to be able to analyze things in your system and look for performance opportunities. And so, we encourage you to, if you can, monitor your data a bit more frequently. Quarterly or monthly data can be like driving in a car only looking in the rearview mirror. You want to look at things closely. And if you're somebody who's got some mastery around understanding variation using common cause and special cause, if you don't understand this stuff, which so many leaders in our industry don't, you'll be tempted to say the data's bad, or invent trends where there are no trends, or explain common cause natural variation as if it was meaningful, or you'll blame people for no reason, or have a pizza party for no good reason. Maybe blame the messenger of your data, or do what Dr. Deming referred to as tampering. And tampering is when you treat common cause variation as if it was special, or treat special cause variation as if it was common cause. And you oftentimes, tampering does more damage to the system and the patients that the system is caring for than otherwise. When you do understand this approach to monitoring data and variation, you'll explain the changes in terms of common and special cause variation. You will always display your data on run charts and Schuhart control charts, using your data and performance over time. And this gives you the ability to really, if your system is stable and it's common cause variation, unless something changes, it should produce similar results in the future. You can use it to kind of predict what's likely to happen in the future. You'll understand stable and unstable, in control and out of control. You'll understand the risks of tampering. You'll know what your process is capable of producing. And so, if you want a quick view of how these charts are built on your own, if you want to know how the sausage gets made, you can take a pile of data, whatever it happens to be, and then you just plot it in its naturally occurring time order. To make it a run chart, you add the median in, and then to make it a control chart, you do the calculation, change the center line to an average, and calculate the 3 sigma above and below. A lot of different software programs do this. My favorite happens to be QI macros. We do this in some of our first watch charts as well. And then once you've seen a shift, you can readjust the data up and down a little bit based on the new process that is producing different results from the process that you started with. And one of the things, a lot of people will come to a session like this and think about all the people that they work with that didn't come to this session. And they'll say that we need to get buy-in from those folks. And I'm actually working with a major hospital system right now on just this this conversation. And their chief quality officer attended a workshop that our friend and colleague Dave Williams did at IHI this last fall, and she was totally convinced to get rid of their standard True North board and wanted to move to this. And she said, "Well, I need to get everybody else to buy in." And I said, "Well, let me tell you about buy-in." And this comes from Peter Senge, the author of the book The Fifth Discipline, and he explained this to me in a workshop I was attending with him in Boston on systems thinking in action years ago. He writes about it a little differently in his book, but I like what he said at the workshop better. So he said, buy-in really talks about 4 levels of employee engagement, and the lowest level of engagement is that of terrorist. And terrorists will actively work to make sure your change idea doesn't get implemented. And the next level up from terrorist is bought in. And buy-in means you've been sold something that maybe you didn't necessarily want. So people who are bought in, this is their posture. And what you get from employees or teammates that are bought in is you get non-terrorism. And if you're going to try to do something meaningful, just standing back and watching isn't enough. The next level up is enrollment, and enrollment literally means putting your name on the roll. You're going to sign up, you're going to help, and you're going to get some of my energy to help with this. And the highest level is commitment. And commitment is, I'm all in, get the hell out of my way. We're going to absolutely make this happen, no matter what we can do. So when it comes to getting meaningful change and meaningful improvement in healthcare in general and EMS in specific, we really need to shoot for commitment. And my experience is, I'm not sure what your experience is like, but no matter how smart I think I am or fantasize or hallucinate that I am, people won't commit to my ideas. People only commit to things that they have a meaningful contribution to designing. As Don Berwick, the founding president of the Institute for Healthcare Improvement, said, "Don't do anything for me without me." If you really want to learn this improvement science and you haven't done it yet, I encourage you to join us for the National Association of EMS Physicians year-long quality and safety program. We actually are doing a PDSA cycle with this course. We've been running this course about, I think this will be our 7th year here. And Todd just dropped the link in. And this course, we're gonna start it virtually in September as opposed to attached to NAMSP. We're gonna try to take summers off and see if that gets better participation. But we encourage you to do that. And I realize that I went through 172 slides in about 55 minutes, which can seem a little intimidating, but I am confident that you can and will be successful doing this. Thank you very much for your attendance. Here is Todd Stout's contact information and mine. Todd always puts his cell number out in public, and he actually means for people to use it. Todd, any last words before we turn it back over to Amy?
No, I think we need to get there. I've got a bunch of stuff that I could say, but it wouldn't sound as good as what you said. So I'm just going to be quiet and give it to Amy.
Okay. Well, great. Thank you both, Mike and Todd, for that presentation. Let me just my screen here.
We do have a question about the recording and the slide deck. So
Yep. Okay. Yeah. Go ahead.
I'm happy to give you the slide deck, Amy, and you can send it out with the recording. Just send it to everybody. That'd be fine.
All right, great. Yeah, we will have the recording available in the next couple days on the Pinnacle website, and we'll include that. And just email me if you can't find it. We'll also be sending it out through email as well. So you should all receive that. But if you have any questions, just let us know and we'll get it over to you. So, all right. Well, thanks again to you both. Thanks also to First Watch for your partnership and for bringing us this presentation. We appreciate you. And thank you also, as always, to our learning partner, Ninth Brain, and our premier media partner, EMS One. And just one final reminder, if you missed it, Pinnacle 2023 is quickly approaching. It will be held July 24th through the 28th in San Antonio, Texas. Be sure to take advantage of the early bird pricing now through June 1st. You can learn more and register at pinnacle-ems.com. And be sure to join us for our next Pinnacle webinar, a least cost approach to optimizing non-emergency transport scheduling and dispatch, sponsored by Bradshaw Consulting Services. Next month's webinar will be held at 1 p.m. Central, Tuesday, June 20th. You can also register at pinnacle-ems.com. Thank you again to our speakers, and thank you all for joining us today, and we will see you next time.
Thanks, everybody. Thanks, Mike. Great job.
Thank you all.